Hello, my name is Dr. Sheldon Wittenvile. I'm an attending psychiatrist on an inpatient unit in Oakland, California. This is a talk that I give to my patients usually once a week. The title is Introduction to Psychopharmacology. Ology from the means study of, pharmo, medications, psycho, mind. So it's medications for the mind. But I decided to put a lot of other things in here as well, and I thought it would be important for most patients to know. So let's go ahead and get started. We're going to talk about the brain, but the brain is part of the nervous system. The nervous system goes throughout the body. The brain is the part that we're most interested in. There are 100 billion nerve cells in the human brain. And the brain looks like this. If you look at it from the side, here's the frontal lobe, the temporal lobe, the parietal lobe, the occipital lobe. If you look at it this way in cross-section, you can kind of get a sense of the brain's evolution. Going down the brain stem, you fall farther back in time in terms of evolution. So the spinal cord is very old. This midbrain part is sometimes called the reptilian brain. Right above it is the thalamus. This is sometimes called the mammalian brain. And above that is the cortex. This is the surface of the brain that is larger in humans than all other animals. Now, in terms of how the brain works, you can look at it in terms of the right brain and left brain, although this is a very gross generalization, and it is true for right-handed people that the left side of the brain is where the language center is, and the language requires a more sequential, serial way of organizing information. So here you have these people in the cubicles doing things in a linear way. The right side of the brain is more holistic and creative. Again, this is only for a small part, really, of the frontal lobes of the brain. And it's reversed for people that are left-handed. It would be the right side of the brain would be the more sequential, logical part, and so on. And for people that are ambidextrous, it's more mixed. Now let's look more specifically at what certain parts of the brain do. Here in orange is the primary sensory cortex. Unfortunately, it's blue down here on the bottom. This is where we first process information from the body. And as you can see, of this piece of brain tissue, about half of it is devoted to the face. The tongues, the lips, the mouth, and so on, and the finger, and not so much the rest of the body. So you can test this, and you know this to be true. If you have an eyelash in your eye, you know it. If you have an eyelash in your mouth, you would know it. But you could have 100 eyelashes on your elbow and maybe not know it. Now, part of that is because there are fewer sensing cells in your elbow, and not as many as there are in the face, but it's also because the brain devotes more space to the face than to other parts of the body. Now, right in front of it is the primary motor cortex, up here in blue and down at the bottom in red. And again, about half of this brain tissue is devoted to the face. Now, that's because we need a lot of control over our face, both for social cues that the face gives, as well as speaking. And the hand here, you see, also has a lot of space to it, and not as much to the rest of the body. Now, you can actually look at the brain in action. These are PET scans, and you can see that when somebody's looking at words, the back part of the brain, the occipital lobe, lights up. This is where we process vision. When we're listening to words, the temporal lobe lights up. This is where we process sound. When we're speaking words, we see the motor cortex lit up, that little bright spot there. That's this spot here, where the mouth is being controlled. And also some of the temporal lobe, because we hear ourselves speak. When we're generating verbs, the frontal lobe, which does more of the abstract reasoning, is involved, as well as the temporal lobe, because we hear ourselves speak. Now, this is a PET scan of somebody who was in a soundproof room, and he was hearing voices. And as you can see, his temporal lobe is lit up in patches, but there's no sound coming through his ears. This sound, he is hearing the sound. He is hearing somebody talking, but it's coming from his brain, not from his ears. And as you can see, it looks quite similar to somebody listening to words. He is listening to words, only they're not coming from the ear. Similarly, when people are having visual hallucinations, the occipital lobe is lit up, and the occipital lobe can't tell the difference between its own generated signals and the signals coming from the eyes. So that's what hallucinations are, brain-generated perceptions. Now, it turns out that fibromyalgia has a similar issue in that people feel pain in parts of their body, even when they're not touched, or sometimes when they're touched, and there's no pain sensation coming from the body. It's the brain that's providing the sensation of pain. People really do feel pain with fibromyalgia, but it's generated by the brain, not from the rest of the body. And there may be other phenomena like this. Now, this is a PET scan comparing the brains of people that are depressed to people that are not depressed, and this is showing the blood flow. Red means increased blood flow, green means decreased blood flow. So here we see what fits with what people say when they're depressed, which is that they're sort of stuck in their head. They're thinking all these negative thoughts. I'm terrible, the world is terrible, And their back part of the brain, which is more processing information from the outside world, here's vision, sound, touch, is less involved, is less active. And even though people, when they're depressed, don't want to do things, they don't want to get out of bed, they don't want to get out of the house, it turns out that you can actually help depression by activating the back part of the brain, going out and doing things, seeing new things, being around other people. Stimulating the posterior or back part of the brain can actually help with depression. Now, just to throw this in here, another thing that helps with depression is not being alone. But it turns out that being alone is not good for any of us. We are social creatures. Being alone is harmful to our mental health, clearly, as well as to our physical health. Just about every physical illness is worse when we're by ourselves. So we always recommend that when people leave the hospital, they have somebody with them. Okay, let's move back to the nerve cells and the brain now. So nerve cells generally look like this. They have a cell body with a nucleus that has the DNA in it. These little things coming off of it called dendrites, and a long thing coming off it called an axon, which conducts an electrical charge. And the axon is insulated with a substance called myelin. Now, we said there are 100 billion nerve cells in a human brain. They have found nerve cells that have as many as 10,000 connections with other nerve cells, which makes the human brain by far the most complicated machine on the planet. Now, the nerve cell can conduct this electrical potential thousands of times a second, actually. It's amazing. And the way it works is, normally the inside of the nerve cell is negatively charged, about minus 70 millivolts, compared to the outside of the nerve cell. Here's the nerve cell membrane. As this charge goes down the membrane, it briefly turns positive inside the cell, and then it goes back to being negative. And again, this can be done thousands of times a second. Now, when nerve cells touch each other, they don't actually touch. There's a little space between them called the synapse. Now, this cell may be conducting an electrical charge. This cell may be conducting an electrical charge. So what we have in between here is what we call an electrochemical junction. So these are chemicals that go between these cells to communicate, but they're communicating with information that's partly electrical. Now, almost all of our psychiatric medications work here in the synapse. Let's blow up the synapse here. So here we see the synapse. These are the receptors. If we blow up the receptors act like a lock with the neurotransmitter. The chemical messenger that goes across the space is like the key. When the neurotransmitter binds to the receptor, it causes changes inside the cell. A lot of different things can happen based on what kind of receptor it is and what kind of neurotransmitter it is. Here's an example of one receptor, and it has 7 pieces in the cell membrane, 1 piece outside the cell. This is where the neurotransmitter is going to glom onto, and 1 piece inside the cell. This is where it's going to cause changes inside the cell. Here's an example of one of the things that it can be done when a neurotransmitter binds to the receptor. G proteins can bind to the inside of the receptor. The G proteins activate an enzyme. An enzyme activates something else. So a whole cascade, a chain reaction of things can occur when the neurotransmitter binds to the receptor. And it takes different amounts of time for these things to occur. Some of these things take milliseconds, as I mentioned. Some things take minutes. Some things take hours. And this partly explains why some of our medications work quickly, and some of them may take days to work. Now, the glutamate receptor, 30% of the neurotransmitter in the human brain is glutamate. And one of the receptors looks like this. It's a tube. And when glutamate binds to the top of the tube, it causes this tube to open. And calcium comes in. Now, calcium is positively charged. So when you put positive charges inside the cell, you make it more likely to fire. Remember, the cell is normally slightly negatively charged. So that's why we call glutamate a stimulating neurotransmitter. It stimulates the cell and makes it more likely to fire. Some drugs like PCP work on the glutamate receptor. Here's another example of the glutamate neurotransmission. Glutamate is released from this cell. It's bound to the receptors here, lets calcium in, and then one of the things that happens is nitric oxide is synthesized. Nitric oxide is not the same as laughing gas. That's nitrous oxide. This is nitric oxide, and it's actually a neurotransmitter that the brain uses, but it's a gas. Just about everything is a liquid, but this is a gas, very small quantities, and it's a feedback signal. The glutamate cell says, I got your glutamate, and it sends it back to the cell that sent it. Now, it turns out that they discovered about 25 years ago that nitric oxide also causes blood vessels to dilate. So Pfizer came up with a drug that increased nitric oxide in the blood, and they gave it to all these old men with heart disease, thinking it would help their blood vessels expand. Well, it didn't, but the men refused to give the pill back at the end of the study. Why? It was Viagra. discovered by accident. It was expanding blood vessels, not in the heart, but someplace else in the body. All of the erectile dysfunction drugs work on nitric oxide, and a lot of bodybuilders are now using nitric oxide because it does expand blood vessels in other parts of the body, including the muscles, and they think that it helps with workouts. Okay, here's a animation of what we just talked about. We're going to zoom in on the brain. Little sound effects here. We see the nerve cells firing thousands of times a second. Then we're going to zoom in on the axon. Now the axon is negatively charged on the inside, so positive ions are attracted to it. And we zoom in here. The positive ions are sitting just outside the cell. When the charge goes down the cell membrane, the positive ions come into the cell briefly, and then they're kicked out again. Now we're going to zoom in on the synapse. And at the synapse here, we see the neurotransmitters. They're coming to be released at the synapse. They bind to the glutamate receptors, which are a tube, and they let calcium in, positively charged calcium ions in. And this is how most of the glutamate receptors work. We're just going to zoom in on it again. The neurotransmitter binds to the receptor that causes the tube to open, and then calcium comes into the cell. Now, the second most common neurotransmitter in the brain is GABA. Actually, GABA and glutamate are both 30% of all neurotransmitters in the brain, and there's a balance between them. GABA is the inhibitory neurotransmitter, glutamate is this excitatory neurotransmitter. In a way, GABA does the opposite of glutamate. It's also a tube, and when GABA binds to its receptor, it lets chloride in. Now, chloride is negatively charged, so when you put negative charges inside the cell, you make it less likely to fire. So that's why GABA is an inhibitory neurotransmitter. GABA, by the way, stands for GABA-aminobutyric acid. Extra credit if you knew that. A lot of medications work on the GABA receptor. Alcohol works on the GABA receptor. Barbiturates work on the GABA receptor. Benzodiazepines work on the GABA receptor. What are benzodiazepines? These guys. All these Ativan, Klonopin, Valium. Librium was the first one discovered. The main difference between these guys is how long they last. Librium lasts about 30 to 50 hours. Valium lasts about a day. Some of them, like Ativan, last about 6 to 8 hours. Then there are the benzodiazepine-like drugs that work on the GABA receptor, but they don't hit all the parts of the receptor like the benzodiazepines. These are the medications used for sleep, Sonata, Ambien, and Lunesta, and you can see these are very short-acting. So they're good to take at night for sleep without making you feel groggy the next day. So the advantages of benzodiazepines is that they work fast. They're also muscle relaxants. They reduce anxiety, and they're almost impossible to overdose on, at least if you take them by themselves. But they have some serious side effects. The main one is this: they're addictive. And along with addiction comes tolerance. That's why you need to take more and more medications to get the same effect. Withdrawal. And then with daily use over a period of years, you can start having memory loss, depression, and even mood destabilizing effects. Especially I've seen this with Xanax, chronic use of Xanax, where people can't control their moods at all. It can alter the sleep architecture. Now, this is not a problem if you don't take it every day. You could take benzodiazepines for a few weeks. You'd be fine if you stop. You could take it for the rest of your life if you took it only 4 or even 5 days a week. But if you take it 7 days a week, taking it for years at a time could cause these problems. Okay, getting back to the brain. Now, what's going on here? This guy's walking down the trail. He sees a snake. So what's happening in his brain? Here's his eyeballs coming right out of the brain. They see the snake. The visual thalamus and the visual cortex and the occipital lobe processes it. What was that thing we just saw? It's a snake. Let's tell the amygdala. The amygdala is sort of the anxiety center of the brain. Let's get panicky. Let's get scared. So the heart rate goes up, the blood pressure goes up, the muscles are ready to go. All this happens before the cortex has even figured out that it's a snake. So this is one of the purposes of emotions, is that it helps us react quickly. This guy's afraid and he's ready to go before he even knows why. So that's how fear works when it's supposed to work. It helps us in that way. The problem is that sometimes the amygdala and other parts of the emotional center of the brain fire when they're not supposed to fire, and that causes some problems. So a little bit of anxiety is a good thing. Actually, people perform better when they're a little bit anxious. But when they get too anxious, they don't perform at all. So there's a problem with called the anxiety performance curve. Also, we were designed for things like snakes, to react to lions, and short-term threats. That's how our anxiety system was designed, if you will. The problem is that we are living in a world now, a society where we can be anxious a lot, sometimes all the time, about different things, about our money, about our family, about our health. And this is something that our bodies are not well adapted to. Chronic stress is a big problem. It causes problems with every part of the body. The brain we'll talk about, fatigue, the heart, the gut. The gut has its own nervous system, but it's very affected by emotions. And we talk about people getting so scared they pee in their pants. People with IBS and other kinds of neurodigestive diseases may have problems related to anxiety, can make it worse, certainly. Weight gain, obesity, decreased sex drive, and difficulty with the muscles like fibromyalgia. Also, as I mentioned, it affects the brain. It actually can cause loss of branches of nerve cells and maybe even loss of nerve cells in general. So stress is not good for any part of the body, and we want to preserve people's brains especially. Now, getting back to the limbic system, these are the emotional centers of the brain. Again, they're deep in the brain, so that means they're old, and they may not react well to the way we live in modern human society. And that may be the cause of some of our mood and anxiety disorders, is a mismatch between the way our brains were designed, our emotional systems were designed, and what we're faced with now in modern human society. Okay, going back to neurotransmitters now. There are more than 100 neurotransmitters, chemical messengers, that have been found in the human brain. These two are gases, but the rest are liquid. We talked about GABA. 30% of the neurotransmitters in the human brain is GABA. 30% of the transmitter in the human brain is glutamate. So the rest of these only make up the other 40%. So they're present in very small amounts. Here are the opioid peptides. These are the endogenous opiates that work like morphine, heroin, Vicodin, all those opiate painkillers. We're making stuff like that, and this is what the runner's high is. People, when they exercise for long periods of time, start to release these endorphins, and it feels good. Now, some medications are now being used that block the endorphin receptors. It turns out that when people fantasize about drug use, I can't wait to have a drink tonight, just fantasizing about having that drink releases endorphins. So some of the medications that can help with craving for drugs like alcohol is to block the endorphin receptors, so then we don't get any kind of high or pleasure out of imagining ourselves drinking or using other drugs. Well, there's also some peptides that are responsible for pain, bradykinin, substance P. Now, this one is interesting, anandamide. So when they were trying to figure out how marijuana worked, they found these receptors in the human brain, actually throughout the human brain. They now call it the cannabinoid system. We still don't know exactly what it does, but the question for a while was, why do we have these receptors? What's supposed to fit in there? What are we making in our brains that's supposed to fit in there? It's this, anandamide, from the Sanskrit word for ecstasy. Turns out if you give somebody anandamide, it's just like giving them marijuana. They have short-term memory loss, maybe some pain relief, they can feel high, they get hungry. So this is our naturally occurring THC, present in tiny, tiny quantities, thousands of times less than what people get from smoking a joint. There are two situations, however, that we know of where anandamide levels rise. One is during pregnancy, and even more so during labor. And that makes sense. If we think of anandamide system and the cannabinoid system as a forgetting system, as a way of getting rid of memories we don't need anymore, and impairing our short-term memory, you kind of want to have your short-term memory impaired during childbirth, so you won't remember how painful it was, and you'd be willing to have another one. Now, it's also interesting that there is anandamide in chocolate, and all you need to do to get the same amount as in a joint is eat 60 pounds of chocolate. Okay, moving to the neurotransmitter systems that we most use in psychiatry, mainly these three: serotonin, norepinephrine, and dopamine, acetylcholine to an extent. Now, these are old systems. They live deep in the brain, as you can see here. That means they're evolutionarily old, and again, may not work well with modern human living. Glutamate and GABA are mostly in the cortex, and that's where we do most of our memory, and our thinking is using glutamate and GABA. These guys, serotonin, norepinephrine, and dopamine, sort of set the tone of the brain. They're not processing information. They're just setting the emotional tone, if you will. Some people think of serotonin as the brightness knob. It turns more serotonin, we see the world more brightly. Now, acetylcholine is a little more recent. As you can see, it's up here in the nucleus basalis of Minard, more recent in terms of evolution, and it's mostly involved in short-term memory. As a matter of fact, with Alzheimer's disease, which is generally about 10 years from diagnosis to death, the first several years are the death of the acetylcholine-producing cells only. And then once they go, the frontal lobe and the rest of the brain starts to go. So the dopamine story is actually quite complicated. The cells that secrete dopamine live here in the substantia nigra, which stands for means dark substance. These are the cells that die in Parkinson's disease. That's what Parkinson's disease is, the death of the dopamine-producing cells. But dopamine does different things in different parts of the brain. In the frontal lobe, we're going to talk about what it does there. It's involved in information processing. In the basal ganglia, it helps control our movements, fine-tune our movements. The nucleus accumbens is a pleasure center of the brain. Every addictive drug that humans have ever discovered puts dopamine in the nucleus accumbens. The most addictive drug that humans have ever discovered is, anybody know? Correct? Nicotine. Serotonin is also a complicated story. The cells that secrete it live deep here in the raphe nuclei, and they project all over the brain. A lot of drugs work on serotonin. Here's sumatriptan, Imitrex. 5-HT, by the way, is the same as 5-hydroxytryptophan. That is serotonin. There are a lot of antidepressants that work on serotonin. Here's a pain medication. Here's an anxiety medication, SSRIs. MDMA, ecstasy, works on serotonin. It causes a flood of serotonin throughout the brain. LSD and all the hallucinogens work on serotonin. So the serotonin story is very complicated, and you can see there are a lot of different serotonin receptors. Now here's the second animation. Let's see if I can get this to work here. So here we have a cell firing and causing a second cell to fire because of what's going on in the synapse. And then we're going to zoom in on the synapse here and see the serotonin is bound to the receptors, and then the receptors let it go, and then this pump recycles the serotonin. This is called the reuptake pump. It's actually an enzyme in this cell that pulls the serotonin back in and it gets reused. Now, some of our medications work by blocking these pumps. We're going to see coming in here the SSRI, selective serotonin reuptake inhibitor, like Prozac, blocks these pumps. The result is that there's serotonin sort of left in the synapse that's not getting recycled, and this cell, the postsynaptic cell, gets to see more serotonin. And this is how almost all of our antidepressants work, by reuptake inhibition. I mentioned Prozac, the serotonin reuptake inhibitors, SSRIs. There's another one called Vibrid here that I didn't put on this slide. But we have Prozac, Zoloft, Paxil, Celexa, Lexapro, and Luvox. They work on serotonin. These two guys, Cymbalta and Effexor, work on serotonin and norepinephrine, so they sometimes work a little better for depression and anxiety. But they have more side effects because they work on more neurotransmitters. Wellbutrin is the only one that works primarily on dopamine. And it has other uses as well, but it's a little bit different in terms of side effects from the other ones because it's working on a different neurotransmitter. I just threw this in here to show how the brain is plastic, which is encouraging news. So what this means is the brain can change in response to its environment. This is with a bat. This is the bat brain. This is the part of the brain, this rectangle here, where the bat processes sound. When the bat is born, it processes all frequencies of sound the same. By 6 months of age, the bat is only processing 60 kilohertz. This is the frequency that it uses for its sonar and for its communication, and it's all it hears as a baby from other bats. So the brain adjusts, and now it's only listening to 60 kilohertz and not the other frequencies. Now, that's obviously true with children. That's how children pick up language, and the brain adapts to what's around it. But it's also true for adults that there may be some ability for the brain to adapt to its environment as an adult too, which is very encouraging. This is done with a monkey, this experiment on the bottom here. They found the parts of the brain that the monkey was using to process information from these fingertips, 2, 3, and 4. Then they glued a piece of plastic to these fingertips, and the brain actually grew because it couldn't sense things from the fingertips anymore. It was numb from these plastic discs. So the brain actually grew more cells in an attempt to try and process information from those fingertips. Very encouraging. Okay, our current understanding of psychiatric illness is that it's a combination of three things: life events or stress, our personality, our coping skills, and our genes. And this is the hot area of research now in psychiatry. I'll talk about that a little bit more. So some illnesses, like schizophrenia, are mostly genetic. We're closing in on what the genetic issues are. It has to do with dopamine and dopamine transport. And it doesn't take much of a stress to trigger schizophrenia. Most psychiatric illnesses require a combination of stress and genes, like depression. The most common trigger for depression is loss of a loved one, loss of health, loss of money. That tends to be the things that trigger depression, but you also have to be genetically vulnerable. And we know depression runs in families. As a matter of fact, alcoholism and depression may run together. I've seen families where all the women were depressed and all the men were alcoholic. It may even be the same gene. But people may turn out they have different types of the depression gene, maybe more vulnerable, less vulnerable. Manic depression, the same thing. That's clearly genetic, at least partly genetic. The most common stressor or trigger for a manic episode is sleep deprivation. Now, there are also some illnesses that don't require any genetic abnormality. It's just that the stress is so big that it causes an illness like PTSD, post-traumatic stress disorder, which is basically misfiring of the amygdala and the anxiety system because it got so traumatized by something. And there's all kinds of symptoms, physical symptoms, emotional symptoms that go along with PTSD. Again, the amygdala and other parts of the brain are overactive. So there's some theories about why we have schizophrenia. We don't know if animals have schizophrenia, but we don't think they do. We think it's sort of a bug that is the result of a new phenomena evolutionarily. The human brain is new, and all the bugs haven't been worked out yet. And schizophrenia may be the price we pay for having a big brain. We'll talk about that a little bit more. There are now some studies showing that schizophrenia does tend to be inherited, but there are twins where one twin will develop schizophrenia and the other will not. And they found that early on, both twins had the same abnormality in their brain. But one of the twins normalized it and somehow caught up and became normal, but one of them didn't and went on to develop schizophrenia. If we could figure out what that normal one was able to do, we might be able to help people early on in the disease and maybe even prevent it. Now, there's also, this is the new thing, and years from now, this is going to be commonplace, where we'll have gene markers that will give us a lot of information about what people are at risk for, including this test, which is on the X chromosome, that tells that women may be vulnerable to certain psychiatric disorders, in particular mood disorders. Okay, speaking of mood disorders, I'm going to say something about mania. A lot of patients that I see who have mania don't realize it, so I wanted to show them what the symptoms are: inflated self-esteem, decreased sleep, decreased appetite, more talkative than usual, racing thoughts, distractibility. And it's important to treat bipolar disorder because it can be a fatal illness. These are standardized mortality ratios. Men in orange, women in blue. Men with bipolar disorder have a 15 times greater risk of committing suicide, and women have a 22 times greater risk of committing suicide. Violent death, homicide, traffic accidents, a lot of other ways that people with bipolar disorder can get killed. So it can be a fatal illness. It's very important that we treat it. In addition, mood disorders in general, both bipolar disorders, manic episodes, depressive episodes, anxiety we talked about, schizophrenia and psychosis we'll talk about, they all can cause damage to the brain. So we want to preserve people's brains. Mood disorders causes atrophic changes or loss of branches of nerve cells. Okay, so here's the periodic table. Why do I throw that in here? Because let's look at it. Here's hydrogen, first element. Second element, helium. Good. Third element, lithium. Good. Lithium is not a drug. People think lithium is a heavy-duty drug. It's an element. It's naturally occurring. We all have some in our bodies. It's actually the most natural medication that we have in psychiatry. It's in the same family as sodium. Here's table salt, potassium. These things taste like salt. They are salt. Lithium is a salt also. And it's also called an alkali metal or an alkali salt, and it has a lot of properties similar to salt because it is a salt. By the way, here's the BR and the BA from Breaking Bad, greatest TV show. Okay, this is an ad from the early part of the 20th century. Think lithium. You know that Coca-Cola used to have cocaine in it. 7-Up used to be called lithiated lemon soda, and it had lithium in it. Now, they had a lot of false advertising back then. You didn't have to be truthful in advertising, so I don't believe any of these things are true, that it's slenderizing, that the sugar is inverted and it burns clean, it blends out the harsh features, takes the ouch out of grouch maybe, dispels hangovers. I don't think so. It does probably settle the stomach. But lithium used to be in 7-Up, no longer. And some people think the reason it's called 7-Up, by the way, is because the atomic number for lithium is 6.94. Lithium has been around. We've known about it for 200 years. We used to think it was good for gout and renal disease. Turns out it can cause renal disease. But it's present in high concentrations in mineral waters and hot springs. We all have some in our bodies. We didn't know it was good for mania until after World War II, especially for bipolar type 1. Prevents recurrence. You can use it in addition to antidepressants for depression. You can use it in addition to antipsychotics for psychosis. And lithium is neuroprotective. This is very exciting news because we talked about how brains can be damaged by bipolar illness and depression. Lithium seems to help the brain preserve the brain. As a matter of fact, this is from September of 2014 in the New York Times, an editorial saying, should we all take a bit of lithium? Why would somebody suggest that? Because it turns out that there's lithium in the groundwater. Epidemiologic studies have shown that areas of the world that have higher concentrations of lithium in their groundwater have lower rates of suicide, lower rates of violent crime and violence, and lower rates of mental illness in general. So it might be worth it to put a little lithium in the water, tiny amounts of lithium. It may help with a lot of different illnesses. I doubt it'll ever happen, but it's a good idea. How does lithium work? Bottom line, we don't know. These are theories about why it might work. Anti-inflammatory, glutamate we talked about, circadian rhythm, that's a good idea because there's a lot of sleep problems in in bipolar disorder. Nitric oxide and glutamate transmission, we're not sure. The problems with lithium is it has what's called a narrow therapeutic window. What does that mean? That means if you don't take enough, it doesn't work. If you take too much, it's toxic. So we have this sweet spot in there where it does its job safely. It can affect the thyroid. It can cause polyuria, increased urination, polydipsia, increased thirst, and all these other side effects, including polyuria and polydipsia, are because of its salt-like properties. Lithium is a salt. If you ate a lot of salt, you'd also be drinking a lot and urinating a lot. Lithium and sodium actually compete for excretion in the kidney. So all these side effects are the same side effects you'd get if you ate a lot of salt. A lot of people with bipolar disorder like lithium because it doesn't seem to fuzz their thinking, it doesn't slow them down. And a lot of doctors I know with bipolar disorder like lithium, lawyers, athletes, and so on. Okay, could we up the dosage? I still have feelings. Other medications that are used for bipolar disorder are, besides the antipsychotics, are anticonvulsants. Now, how do anticonvulsants work? Anti-seizure medications. Well, there's two ways. Generally, either they inhibit glutamate, which is excitatory, or they facilitate GABA, which is inhibitory. So you see here these anticonvulsants that are used in psychiatry, like Depakote, this most commonly used for bipolar disorder, increases GABA and decreases glutamate. It's also used for migraines. Can cause weight gain and loss of hair. That's uncommon, but a serious problem, obviously. Tegretol increases GABA, used for bipolar disorder. It can cause sedation and a number of potential dangerous effects on the liver and the white blood cells. Neurontin, gabapentin, 5 GABAs, that's what it means. Increases GABA, as you might expect. Doesn't work for bipolar disorder, but does work for anxiety, maybe benzo withdrawal, maybe pain. Lamictal is used for bipolar depression, doesn't seem to work for mania. Has a risk of severe skin rash. 1 in 1,000. Memory problems are also an issue. Topamax, even more memory problems are an issue. Topamax is mostly used in psychiatry for weight loss. Sometimes we'll add it with our medications that cause weight gain to try and counteract the weight gain problem. Trileptal, also useful for bipolar disorder. Okay, I don't mind the voices themselves, doctor. It's the Jersey accents that are driving me nuts. What is psychosis? Psychosis is gross impairment in reality testing, out of touch with reality, as evidenced by delusions, fixed false beliefs, hallucinations we talked about, a misperception, a brain-generated perception, disorganized speech or behavior, and catatonia. Catatonia means being awake and unresponsive, kind of like a zombie. These are the 4 symptoms of psychosis. You only need one to have the diagnosis of psychosis. A lot of different things can cause psychosis. We think that the final common pathway is excess dopamine in the frontal lobes. Now, there may be other things to do with dopamine, but we're pretty sure it has to do with dopamine. It may not be excess dopamine, it may be something in dopamine transport, but dopamine is clearly involved in psychosis. So if it is excess dopamine, that would explain some things, and this guy's hearing the voice of the devil. And one of the reasons we know it has to do with dopamine is because all the antipsychotic medications work by blocking the dopamine receptors. So we block the dopamine receptors, he's no longer hearing the voice of the devil. Now, the psychiatric illnesses that can cause psychosis, there's some that is the problem. Psychosis is the problem, like schizophrenia, drug-induced psychosis, schizoaffective disorder. Brief reactive psychosis, that's what we probably used to call a nervous breakdown, briefly psychotic. Shared psychotic disorder, interesting illness, folie à deux. And then psychosis can be an associated feature of mood disorder. So when people are really manic, they can become psychotic. Usually it's a grandiose kind of psychosis. I'm the greatest person that ever lived. Everybody loves me. I can do anything. And when people are depressed, up to 15% of people who are depressed can become psychotic too, with a negative psychosis. I'm the worst person that ever lived. All the world's problems are my fault. Everybody hates me. Other illnesses can cause psychosis. A lot of medical things can cause psychosis as well. I'm not going to get into that right now. Psychosis, like mood disorders, like anxiety, can cause loss of brain cells. So it's very important that it be treated so that we preserve people's brains. True in all psychiatric illnesses, we're trying to preserve people's brains. So the first antipsychotic was called Thorazine, discovered in the late 50s. It was actually tested as an anesthetic. That was originally what they wanted to use it for, but it didn't put people to sleep for surgery. It did calm them down. Then they gave it to people with psychosis who were hearing voices, and it made the voices go away. So it was discovered by accident, like a lot of medications were. This is an ad from a 1960s psychiatry journal. When the patient lashes out against them, Thorazine quickly puts an end to his violent outbursts. Yes, it does. Thorazine is very sedating. These are the older antipsychotics, now called the typical antipsychotics. Mellaril is not used very much anymore because of some heart side effects, but these are still used sometimes, and I'll explain in a minute why we don't use them as much. Then we have the newer ones that came out in the 90s that we use a lot more: risperidol, Zyprexa, Seroquel, Geton, and Abilify. There's a couple more I'll mention, and maybe by the time you see this, there may be even more. So here's the conventional antipsychotic from Stephen Stahl's book, Essentials of Psychopharmacology, really the best book on psychopharmacology. A lot of great pictures. And you see here the dopamine D2 receptor blockade. All antipsychotics have to block the dopamine D2 receptor in order to have antipsychotic effect. But there's also other receptors that the older antipsychotics affect: muscarine, histamine, alpha-adrenergic, and that caused a lot of side effects: constipation, blurred vision, dry mouth, weight gain, sedation. And this one is the worst one, which is when you block dopamine in the basal ganglia, which the older antipsychotics do. They block dopamine in a lot of the brain. We only want to block it here, but if you block it in the basal ganglia, you can have extrapyramidal side effects, meaning muscle spasms or tremors, increase in negative symptoms. So we had to give people medications to counteract the antipsychotic side effects: Benadryl, Cogentin, Artane, Simitril, vitamin E. So we were very happy in the mid-90s when these new antipsychotic medications came out. So here's the older ones. Here's the newer ones. They all have this dopamine D2 receptor blockade, but they also have this silver triangle here, 5-HT2A, which stands for 5-hydroxytryptophan. Again, serotonin, the 2A receptor is blocked. And when you block the 2A receptor, you really only end up blocking dopamine release in the frontal lobes. You don't want to block dopamine in the basal ganglia, as we said, and this allows for dopamine to be still used in the basal ganglia, so it doesn't cause the muscle tremors, the tardive dyskinesia, which can be a debilitating permanent tremor that the older medications could cause. So we were very happy when these new ones came out. Here's an ad for one of the really new ones, Fanapt. This is an ad from a psychiatry journal. Now, instead of saying when the patient lashes out against them, they say, here's the receptors that it works on. Here's the newest antipsychotics, Latuda, Fanapt, and Vega Saphris. They work pretty well, probably have fewer side effects than the ones we're using, but they're very, very expensive. Invega, as of this time that I'm recording it in October of 2015, costs about $450 if you paid for a whole month's prescription of pills. It's also available as a once-a-month shot that only costs $2,000, or an every 3-month shot, Invega Trinza, which is a great advance in being able to get a shot every 3 months, but that costs about $5,000 to $6,000 a shot. It'll come down in price when they become generic. So the older antipsychotics, we only used them for psychosis because they were so dangerous. Occasionally we'd use them for bipolar disorder when nothing else worked, but we didn't want to cause these nasty side effects. But these new ones don't have those side effects, the muscle side effects in particular, so we use them for so many things: psychosis, bipolar disorder, agitation, anxiety, sleep disorders, especially Seroquel, personality disorders, depression, and so on. So the good thing about the new ones, they don't have the extrapyramidal side effects or tardive dyskinesia. They help with mood. Its affect is mood. They can help preserve the brain. Schizophrenia, you can't overdose on them. But here's the big side effect: weight gain, especially Zyprexa. 40% of people have a 7% increase in their weight. Again, the majority of people will not have weight gain from Zyprexa, but 40% is a lot, and 7% is a lot of weight to add on. And along with the weight gain can come diabetes, stroke, and so on. And they're new and expensive. And this is what it can feel like on Zyprexa or some of these medications: is people are always hungry, like they're getting sucked into the candy store. No matter how much they eat, they're still hungry. This is a new study that showed that the gene for causing Zyprexa weight gain is similar to the gene for schizophrenia and autism. So this is a little scary. I mean, it's good in some ways that we might be able to do a gene test and say you're at risk for weight gain from Zyprexa. On the other hand, it may be that the same thing that Zyprexa is treating schizophrenia, maybe even autism, is also what causes obesity. So we may not be able to separate the side effect from the benefit. Hopefully we will. Here's the risk of weight gain increasing as you go down this list. Geton is the least likely. Risperidol is kind of in the middle. Seroquel is getting up there. Zyprexa and clozapine is the worst. So last thing I'm going to say is, why don't people take their medications? I go to psychiatry conferences all the time, and we talk so much about why don't people take their medications. Look how well our medications work, but they don't take them. Why don't people take them? Lots of reasons. They don't like the idea of medications. They don't work. They cause side effects, physical or psychological side effects. People feel like they're going to be addicted to it, or it's a crutch, or what does it mean about me? I don't like to be reminded I have an illness. I don't like the idea of medications. Lots of reasons people don't take medications. And it turns out that among bipolar patients, 40% stop treatment within a year, and 50% of patients with schizophrenia don't take their medications. Very high percentages. Again, that's why those once a month or once every 3 month injectable medications are a big advance. So what are the consequences of not taking medications? Well, here are people that were discharged from the hospital, and here's their chances of coming back to the hospital in the next year, depending on versus how long they stopped taking their medications. So here are people that took their medications 365 days a year. They still had a 6% chance of coming back to the hospital. And here are people that skipped their medications for more than a month. They had a 22% chance, almost a 1 in 4 chance of coming back to the hospital. So bottom line is, if you're happy and you know it, stick with your dosage. Hope this was helpful. Thank you for listening.